Okay, great. Good to see everyone this morning. And so I want to introduce Dr. Neil Pliskin. He is a board certified clinical neuropsychologist and psychiatry and neurology professor at the University of Illinois College of Medicine. Dr. Pliskin is director of neuropsychology services at UI Health and has 35 years of experience as a clinical neuropsychologist and directing clinical neuropsychology training programs. He's a fellow of the American Psychological Association and the National Academy of Neuropsychology, and he was awarded a presidential citation by the APA in 2010 for dedicated service to the profession as an advocate, scientist, educator, and practitioner of clinical neuropsychology, and also awarded the Distinguished Neuropsychologist by the American Academy of Clinical Neuropsychology in 2023. So we have a very distinguished speaker with us this morning. Thank you for joining us, Dr. Pliskin, and go ahead and you start your talk anytime.
Thank you. I'd appreciate that. So I've been at University of Illinois since 2001, but I actually started my career at the University of Chicago in 1988, if you can wrap your mind around that, and worked closely with cancer patients in the cancer center there. Actually published a paper years ago on OKT3 and neurocognitive functioning. So I'm going to talk today about the cognitive effects associated with cancer and its treatments. And the first thing I should do is share my screen. Okay. And I'll tell you right now that I'm a little intimidated giving a talk like this to a group of people who work with this population or are intimately familiar with cancer every day. So if you feel the need to roll your eyes from time to time, going, oh my God, he's telling me stuff that I do every day, then I apologize in advance. But I'm going to talk to you a little bit first about what neuropsychology is for those that have not had much interface with neuropsychology. And then I'll talk about the cognitive effects of cancers and cancer treatments. I'll do the best I can with that. And if there's time left over, part of it is about like, what do you do to help people? So that's what my ambitious goal is. And I'm going to start by talking about what I do and why it's relevant. Okay. So let me begin at the beginning and say that I am a PhD. I am not an MD. And I am a clinical neuropsychologist, which is a specialty, a subspecialty of clinical psychology devoted to understanding and assessing the relationship between brain functioning and observable behavior. I'm a doctoral level clinical psychologist, and if you want to be a neuropsychologist, you got to go through a fair amount of training, including a postdoctoral fellowship. Board certification is not like in medicine. It's completely optional here, but board certification is the best evidence that somebody knows what they're doing. And the reason why this is important and why I harp on this is because, except for the state of Louisiana, if you get a license in Illinois to practice psychology, then anybody who has that license can purchase neuropsychological tests, sign their byline neuropsychologist, and be perfectly within their scope of practice to do so. So the issue here is that you need to make sure that you're dealing with board certified people. And of course, we have a, a fellowship training program here, and we've been training folks for 2-year fellowships for as long as I've been here. And the other thing to tell you is that we do more than just evaluate patients. We're clinical psychologists first. So we do health and behavior work. We're PhDs, and some of us are PsyDs, so we're doctoral level folks. So we bring a fair amount of skill to the and a diversity of our portfolio to the table. And I'm telling you this for a reason, which you'll find out in a couple of minutes. So when we talk about measuring cognition, which is a large portion, but not all of what we do, we're not talking about screening. We're talking about evaluating and appreciating a broad range of cognitive abilities, which I'll show you more. This kind of evaluation, it's portable and it's objective. And that's a key theme here, because one part of what you learn is from talking to the patient. And one part of what you learn is by gathering objective information about the individual. Whether we're giving these tests, which are mostly paper and pencil, mostly paper and pencil, some computer and other types of tests, are given in a standardized way, which means that whether I give this test that you're seeing now, called the Wisconsin card sorting test, in Chicago, Illinois, or a colleague of mine is giving it in Tuscaloosa, Alabama, if you put them side by side, the test administration should look exactly the same, because under those circumstances, it allows us to compare how that person and in their age group performs. And I say biases because, these tests are developed on English-speaking North Americans educated in the US. And we know that that does not represent, clearly the range of individuals that we see at UI Health. And so this is why, you do no harm means that you understand the strengths and weaknesses of the tests that you give. Doing a test like this, what you see in this picture here, it's like taking a fancy photograph or video clip of someone. You're catching them at a moment in time, asking them to perform their best and seeing how they do and comparing it to other people their age. I can look at that photograph and I can tell you what that person's cognitive abilities, assuming I could communicate with them effectively, and I had appropriate norms to compare them to, I could tell you what their cognitive functioning is right now. Sometimes I can look at it and say, I know what they're going to look like. But a lot of times it's like here and now information. And so I give somebody a 16-item word list. They remember 8 words out of the 16. I compare it to other people their age. If they remember a certain number of words and they're 1 standard deviation down, then we would say they're mildly impaired. If the number of words that they learn is substantially down relative to their demographically matched peers, then the objective information says that they fall at the lowest end of the bell-shaped curve. So that's the objective element of what we do. We take somebody, we put them in a quiet environment, free of distraction, and we ask them to perform their best. Now, probably 75% of the people on this Zoom meeting recognize this. This is the Montreal Cognitive Assessment, the MoCA. Colleagues, this is not a neuropsychological test. And giving the MOCA is not a neuropsychological evaluation. It's a screening test. And the important element of a screening test is not meant to infer a diagnosis, but rather to indicate whether further evaluation is needed. Because there's so many reasons why someone can perform poorly on something like this. I've just indicated one, which is language, or another, which is education. And yes, you can tell me that the MOCA is available in 20 different languages, and it's true. But the value of a screening test is to increase the identification of at-risk individuals. So in a system that works seamlessly, we have MOCAs, we have people doing MOCAs, and then we establish criteria for when more detailed testing is needed. And this is exactly what we had been doing for a long time with the occupational therapists on the stroke service. To make my point clear, so that you don't think I'm just a shill for my profession, here's an example. 58 brain tumor patients. 39 of them completed comprehensive neuropsychological assessment, and their data was used for sensitivity and specificity calculations compared to the mini mental state exam and the MOCA. And the bottom line is that when you give the mini mental, 33% of the patients diagnosed as cognitively impaired on formal testing had a near perfect score. On the MOCA was only slightly better. So they're neither sensitive nor specific. That's the problem. And of course, you can't run around ordering neuropsychological tests on every patient. So it gets complicated, and that's partly what I want to talk about. But when you get a neuropsychological evaluation, you're getting a comprehensive evaluation of that person's cognitive and psychological capabilities, because I wear two hats. I'm a clinical psychologist and I'm a clinical neuroscientist. So a little bit of show and tell of some of these neuropsychological tests. This is the Hopkins Verbal Learning Test. It's the individual is not told that their list of 12 words can be grouped into four-legged animals, precious stones, and human dwellings. They're read the list, and after each trial, they're asked to recall. Then they're read the list again, asked to recall, and so forth. And then after a 20-minute delay without warning, we say, by the way, do you remember that list of words we read to you before? How many can you recall now? And the objectivity here, and then there's a yes or no. Was this word on the list? Yes or no. Was this word on the list? So there's we don't expect somebody, here's the sad reality. I turned 66 this year. My memory at 66, not the same as when it was 46 or 26. And I'm pretty healthy, knock on wood. So memory changes as a function of age. And so as a result, one can't use a test without also using the appropriate comparison group, carefully screened to rule out neurologic and psychiatric illness. We test visual memory. Here, this is called the brief visual spatial memory test. 10-second exposure, take it away. And then we if I told you that this person was 88, you might feel differently about it as if I told you that this person was 48. And then there's like a bunch of different kinds of memory loss. There's the rapid forgetting memory loss, which you're not going to see that often in cancer patients, but you'll see much more often in dementia patients. But rather what you'll see are more problems with concentration and learning information accurately on the front end. Here's an example of what I'm talking about. And after I'm done showing you this sequence, think to yourself whether this is a forgetting problem or not. So I show this figure for 10 seconds, then I take it away, person does this. So right off the bat, there's some loss of information there. That's a concentration issue. Now I show the patient a second figure, and look what this patient does. There's elements of the 2 lines crossed 4 flags. There's elements of the figure that you're seeing here, all combined. So this person doesn't have a forgetting problem. They remembered 2 lines crossed 4 flags. They remembered boxes. But it was the organization and the accuracy that was affected. And that is a lot of what you see in patients who have front-end concentration and working memory problems. And that is a huge element of what we'll be talking about when we turn to the topic of cancer-related cognitive impairment. Now, some of my patients, they just don't care that much, or they have other things on their mind when we ask them to recall information. But this highlights the fact that you have to really be trying hard to do your best on these tests for them to be helpful. And we have ways to make sure that people are doing that. And then there's people who have very severe and focal cognitive impairment that affects, key cognitive abilities, like this person who has a non-dominant hemisphere lesion. This is their copy of the figure on the upper left corner. And we also do things related to reaction time and sustained attention, especially relevant, again, with cancer patients. The instruction here is press the blue button every time you see a 1 followed by a 9. Check it out. There's the 1, there's the 9, press the button. Now imagine that going on for 8 minutes. The task measures reaction time and whether you are having lapses in your mental focus. Here's the second condition, same instructions. Oops, this isn't the one I want to show you. There's a second condition, and I'm going to digress for a moment because I want to show you this second condition. Because some people would look at that and they go, well, that looks pretty easy. 6 minutes of that's not so hard. But okay, so now let me go back to sharing my screen. Here's the second. And on this one, it's still the same instruction. Watch for the 1, then that's followed by a 9 at the center of the screen. 6 minutes of this. Got to just watch the middle. Now just imagine being a resident on call for 48 hours and trying to do that task. Okay. So let me go back to my. Okay. Moving on. So everything that we do, we talk about it as objective impairment. And I want to point out that there's different levels of testing, and just follow the bouncing arrow. The cognitive screening is your MOCA, and anybody can do that with training. A lot of what we're going to be talking about is cognitive testing, not terribly detailed testing, but more focused testing, versus the neuropsychological assessment, which you would really want to give only under selective circumstances. And a few years ago, I was invited to be part of a think tank for emergency medicine doctors who were concerned about how they could quickly recognize patients who come to the emergency room who have cognitive impairment. And we broke off into focus groups, and we talked about what was needed. And every time I present this slide to neuropsychologists, they all break out laughing. But this is what they concluded: that the ideal tool would be brief, practical, simple, don't need any paper or equipment, intuitive, so you don't really need much training, but it's got to be high sensitivity and specificity and reliable. And my neuropsychologist colleagues go, is that all? But the reality is that that's what's needed, especially when you're talking about large populations of individuals. And neuropsychologists have to be prepared to give shorter batteries of tests. And that's this middle level of cognitive testing. And here's why it's important. I'm going to turn now and talk about and pivot to why I've brought up these certain issues in discussing cognitive testing. Let's start with this. The number of cancer patients seen in UI Health Neuropsychology, 37, and thus far 13. We see over maybe 800 patients a year. You know what I call that? I call that pathetic. And that's because we have silo-based care. And by we, I mean me. And we have worked hard to have an interdisciplinary memory and aging clinic, an interdisciplinary epilepsy surgery clinic, an interdisciplinary pain program, bariatric surgery program. But neuropsychologists have lagged behind. And I think the reason, and at some point, if I don't prattle on too long, I'd be interested to know how other people perceive this. But I perceive this as out of sight, out of mind. And when you're dealing with cancer patients who have so many complicated medical and psychosocial and social determinants of health issues, sometimes cognition isn't well appreciated, or maybe there's institutional obstacles that we need to be more aware of. But this is why I'm harping on some of this, because to have only seen 50 patients in 2 years is well below what should be occurring if there were tighter connections and more integration. And I take responsibility for that. I've already said I've been here for a long time. So let's now talk about why. It's debilitating for patients. And a lot of the studies that have been done with breast cancer. But now they're starting to do studies looking at cognitive issues associated with immune, endocrine, and other targeted therapies. And an urgent, as the survival rate has increased, there has been increased need to understand what side effects people have and what the implications are for quality of life. And by the way, feel free to roll your eyes at that one, since I'm sure you're dealing with this all the time. But when we talk about cognitive dysfunction, it can be present in cancers at the time of diagnosis, especially if you're talking about, primary brain tumor or paraneoplastic disease. It can be present during cancer treatment. It can be dose dependent, and it can be seen weeks and in some studies years after treatment. The exact incidence of and prevalence of cancer-related cognitive impairment is unknown. The quality of the studies, it's clinical research. I remember from those days where you catch people when you can catch them, and different institutions tend to see different types of patients. So it's not a huge surprise. And also, if you march 5 neuropsychologists into the room, you're going to get 5 different test batteries, even though there have been attempts made by the neuropsychology community to standardize some of the testing that can be done with cancer patients. And by the way, I'm not talking about comprehensive neuropsychological evaluations here of 6 hours. I'm talking about that middle column of more focused cognitive evaluations, because we need to, depending on where the lesion is, we understand what kinds of tests we need to give. Or if the person is experiencing difficulties post-surgery or post-chemo or radiation, that implies different kinds of cognitive impairments, and you give different kinds of tests. So the cognitive effects of CNS tumors are variable. And so if I have a patient who has a frontal lobe lesion, I'm going to approach things a different way than if I have a patient who has a temporal lobe lesion. But some of the common cancer-related impairments include difficulty with multitasking, paying attention, decreased drive and motivation, a loss of anhedonia, a loss of interest in or ability to take pleasure from pleasurable activities, word-finding problems, changes in temperament, eye roll again, and changes in mood and personality. And the memory loss that we have in this population is not a memory loss of, I can't remember the last 20 years of my life. The memory loss that we have in our cancer population is, I can't remember things going forward. I'm more forgetful. I'm missing conversations. I'm losing things. And, neuropsychologists, it's like suddenly brain fog has become the term of art as we have gone through the pandemic. And I tell anybody that we've been hearing complaints of brain fog for as long as we've been working with patients who have cancer and those who are being treated. And it's characterized by decreased rate in learning new information. What is typically automatic is no longer automatic. Some of you right now are listening to me. You're looking at your email. You're thinking about your day, and you're processing what I'm telling you, especially if I make my talk interesting. And you're doing it automatically. But there are one of the areas that becomes especially problematic for people who have decreased bandwidth, as reflected by decreased learning and attention and executive functions, is it's harder for them to do the automatic things and multitask. And The prevalence, this is something I want to talk to you about. The prevalence, when you ask your patients, are they having cognitive impairments? The prevalence in studies goes as high as 3 out of every 4 patients. But when you look at the neuropsychological literature, again, mostly with breast cancer patients, post-chemotherapy, the rate is like closer to 33%. So you have multiple mechanisms related to chemotherapy that are causing cognitive impairment. The possible mechanisms are highlighted here. Impaired neurogenesis, oxidative stress. And when you look at meta-analyses that have, so this slide, and I have the references at the end, is highlights 4 meta-analyses that have combined like 20 years worth of work of looking at cancer patients and cognitive performance. And the black parts of the bar reflect those studies that indicate impairment in these cognitive domains. So to make the point more clearly here, executive functions, processing speed, finding the right word when talking, some aspects of memory, and the biggest complaint everybody has is short-term memory and working memory. And in my world, short-term memory and working memory is like your concentration capacity. Like, I'm going to give you a telephone number, and then I'm going to ask you to do 2 other things, and then I'm going to ask you to remember the telephone number. It's like your short-term, very short-term sketch pad. And so, I like the way that this study from 2018 highlights how complicated the cancer-related cognitive impairment is. So you have all your mechanisms of potential cognitive impairment induced by chemotherapy or immunotherapy, biologic therapy, endocrine therapy. And then on the other side of the fence, you've got how healthy were they to begin with, and how much organ dysfunction is there? What's their nutritional and fluid balance? Are they anemic? What's their genetic predisposition? All of those contribute to, so that you have treatment-related factors and you have patient-related factors that contribute to cognitive impairment. And if any of you are saying, so what? Cognitive impairment is cognitive impairment. I respectfully will present a case to say that it's not so what, because some of these factors that we're going to be talking about are potentially modifiable. So here's just another representation of where cognitive functioning and why neuropsychological services need to be integrated closely with oncology and neuro-oncology, because you have your subjective complaints, you have your objective performance, and then you have all of your other factors, non-medical factors, comorbidities, rehabilitation issues, and social determinants of health, all of which play a role in how that individual presents. And Betty Rogenkamp, I promise you, before I'm done, I will cut my talk short to ask to answer this question of what do you do about it? Because that's really critically important. So I've made this point now several times, but here's what I want to point out. Patient-related cognitive symptoms, 78%. I'm cherry picking the study to make my point. Cognitive performance and neuropsychological, 33%. So that implies that there are potentially some modifiable factors that could play a role in why someone is presenting with cognitive impairment. So I've now ensured that I will answer your question, Betty. So we need to be working more closely together. Neuropsychological assessment is important in identification and localization of cognitive impairment. If somebody's got a brain tumor, then the question becomes how independent can they be and how safe are they? If they have a right-sided meningioma, for example, versus a right-sided astrocytoma, the question is always going to be to balance off, in my world, the question is always going to be balancing off the level of independence of the individual to maintaining their safety. And that is a very slippery slope because people want to maintain their independence and they don't want to be told that they can't drive. They don't want to be told that they need supervision. So cognitive impairment is a key factor that influences quality of life. So I say that maybe one of the reasons why you see this huge cherry-picked 78 versus 33% difference is because that there are modifiable factors in addition to the cancer, in addition to the cancer-related adverse treatment effects, treatment-related adverse effects. And part of that involves recognizing and addressing the psychological and psychiatric issues. Cue the next eye roll. Okay, so here's a very busy blueprint of how we can work together before treatments, during and after treatments, using brief screeners, using focused cognitive testing, and for those patients that need it, more detailed assessment. Why? Because some of those factors may be modifiable factors. If someone has depression, that person may look different than the individual who has cognitive slowing for other reasons, like the impact of their medications or the delayed effects of focused radiation. So there's potential interventions here. Some of them really are very straightforward. Exercise, and of course, that has to be defined in a different way depending on the physical condition of the patient. But active exercise increases oxygen in the blood. And all I can tell you is that if I had $1 for every time somebody asked me, should I be using ginkgo biloba? Should I be using the Prevagen or some of those other scientifically unproven approaches to helping with cognition? Well, guess what? exercise is number one. For those patients who have, health-related anxiety issues, getting relaxation techniques and mindfulness meditation, extremely helpful. And those patients who have those patients who really need professional help in managing those symptoms, cognitive behavior therapy is certainly the way to go, as well as educating the family in how to help the individual and helping the individual to reinvent themselves. If their surgery caused them to have partial blindness, helping them to reinvent. If they're used to being the top earner and the top performer in their office, some reinvention might need to happen. So I'll take 5 more minutes and then I'll stop for questions. So you have patients who have memory loss. You have to repeat instructions. You have to have them write information down. I tell individuals, if you keep losing your keys, label a spot for your keys, and that's your orientation center. Maintain a consistent routine. So the person recognizes that they're having difficulty recalling recent events. Strategies: keep a personal journal for the day's events. By the way, I'll be happy to make these slides available. Review the calendar to assist recalling recent events. And the calendar should contain specific details about the appointments. How about someone who's having difficulty remembering to take their medications? So someone who occasionally forgets or becomes confused. Strategies: well, obviously, work with the prescribing physicians to review the medications. Colored flag placed on pill box. Move the flag once the medications are taken. Pill reminders and dispenser products. There's some really fancy ones out there now. And then addressing memory issues in daily life. Social withdrawal from fear of forgetting names of friends. Well, for misplacing things, take your most important items and choose that one spot. Or get occupational therapy focused on memory strategies. Use a large calendar to write many details about the appointments. We've talked about that, and review it daily. Use a whiteboard. And for the fear of forgetting names and friends, have them bring a cheat sheet with names and/or pictures of friends. And I tell people, your brain is not a muscle, so you don't have to keep testing people. I'm not going to tell you, you tell me. All that does is end up in frustration. And remember that some of the issues that cancer patients have are tied to their treatments. So some patients, as their treatments regimens are completed, will no longer have these same kinds of problems. So how about those with communication issues? Speak in simple sentences. Make a memory or a communication notebook. Devise a strategy for emergency situations. Always consider seeking the intervention from a speech and language pathologist. So Difficulties with communication leading to more tension, strategies. Ask clarifying questions if it's you. Don't assume you understand. Remove all distractions. Speak face to face. Use short and simple sentences. Yes or no. What's on the menu for dinner tonight? How about managing symptoms of visual problems, like keeping personal items in the same spot, arranging clothing within categories by color, use verbal labels around the house, make sure that there's no obstacles that could lead to someone falling, if their visual acuity is good enough. So if they're having trouble locating items around the house, patient's not able to see items in plain sight, strategies, remove clutter, provide contrasting color. Step back from the surface and reapproach. If it's you're the one that's having the visual problems, or you're advising patients who have visual problems, step back, step forward. And then, as we know, cue eye roll. Many individuals really struggle emotionally and behaviorally. The family needs to understand the changes that someone is going through. Consulting with the physician for medications to manage difficult behavioral symptoms. Sticking to a regular schedule with structured activities. I've had many patients where the spouse says they've just gotten lazy. They're lazy. What do you mean? Well, we talked about doing all these things and he just sits there. Well, if you ask him, or if you tell him what to do, will he do it? Well, yeah, but I shouldn't have to ask. And that might be true, except when you're talking about someone who has motivational inertia, which then requires educating the family to take a more active role in managing that patient. Don't give the patient a choice. Yes, we are going out to dinner tonight. And there again comes that, where do you draw the line between recognizing and preserving the person's independence versus making sure they stay safe? So does the person seem apathetic or disinterested? Well, the patient isn't completing daily hygiene activities or other activities that involve multiple steps. Well, one thing is make sure that you know what their cognitive status is, and then divide things into small parts and provide step-by-step instructions. That's a big change, in relationship. An emphasis on everyday events and activities of daily living, helping the person to be independent in even basic self-care activities, and being practical. Keep things simple. Get rid of clutter. Follow a routine. Make mealtime simple. And what can be done for caregivers? Education, 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 respite, support. Be proactive.
Thank you, Dr. Pliskin, for this excellent talk, talking about something that very few of us knew much about. And don't feel bad, like you're talking to a bunch of oncologists, because I don't know there's one oncologist here today.
Oh, I wasn't even thinking about that, but that's still everybody on this call.
Yeah, we're up.
In one way or another.
Yeah.
So that's
Yeah.
like Yeah.
Yeah, I could see the intimidation factor, but yeah, we're all learning this, and loved your talk and bringing up all these points about this excellent thing. Dr. Jimbo was saying thank you for all these practical tips, and yeah, definitely in our approach to patients, all of this is just incredibly helpful. Um, because it's something not a lot of us know how to approach. Occupational therapy may be kind of one of the best girded kind of specialties in neuro, obviously, but a lot of us can learn a lot about it.
Well, it's a moving target
Mhm.
because you have some individuals who are right in the middle of their chemotherapy, and they're going to be experiencing, substantial front end concentration and short-term memory problems. We know that because every single study shows that. But then there's, what I call the freak out factor that happens.
Mm.
Oh my God, uh, I'm so sick, I'm losing my mind. I'm not going to be able to function. I'm not going to be, and they go down this dark alley that then leads to huge levels of distress and preoccupation, and as if there's not enough trauma already, it's trauma.
Mhm.
So um, so helping people to understand the short term, uh, potentially reversible changes. And then, you have folks who have more persisting problems. And I'm I'm leaving out our our brain tumor patients. Um, and then mostly I'm leaving them out because uh, like real estate, it in part at least, it's location, location, location. But the other part of it that I know from my work with MS patients is when that immune system gets activated, and especially some interferons and some interleukins uh, have adverse effects on neuronal functioning and uh, produce fatigue and lethargy and mental slowness, and as a result, uh, some of those cognitive changes can persist even after the treatments are are complete, or I guess I think you would say they've completed their treatment regimen. So
Yeah,
part of it is, what are the modifiable factors?
right.
How much of this is depression?
Mm.
How much of this is the freak out factor? Um, and and how much of it is appropriate health related anxiety? And if it's health related anxiety, um, then health psychology, neuropsychology, clinical psychology, social work, all critically important in helping to
Mm.
um, manage the anxiety related components.
Definitely, this multidisciplinary type of treatment of these patients, I think, like you say, we're kind of siloed, and it's important to all collaborate together.
Yeah,
And
and one last point is that those patients who got whole brain radiation, especially in the last decade, um, if they've survived, may also have uh, significant cognitive impairment, and that kind of cognitive impairment would look very different than the kind of cognitive impairment that we're talking about in the short term. So sorry to have interrupted you, Dr.
that's
Mintz, but I
okay.
just wanted
That's
wanted to
okay.
make sure that point was clear.
Yeah, I wanted to circle back and kind of like what you're talking about, these modifiable risk factors, and kind of a question I was thinking of is related to Betty's question, related to something you said. Betty asks, is diet something that can affect? And I was thinking, particular anti-inflammatory diet to decrease these levels of those interleukins and those inflammatory factors. Is that something you've seen that can be helpful?
Theoretically, yes. I haven't personally seen it, but I haven't looked at that too closely.
Yeah. I mean, I recommend any patient anti-inflammatory components in the diet to decrease processed foods, red meats, sugar, salts, everything, because going more anti-inflammatory is going to help many, many health states, including potentially helping to retain or improve cognitive function.
Well, if you walk away from nothing else from this talk, walk away from the idea, and you're reinforcing it again, Dr. Mance, that it takes a village. And right now, uh, we're not part of your village, and we need to be part of your village,
Yeah.
because you can teach us things and we can teach you things that will all help in the care of your patients. And
Yeah.
always reach out to me anytime.
Yeah, I know some people are shuffling out. I don't know if you have to leave, Dr. Pliskin. I know some of us may still have questions. Does anyone else still have other questions for Dr. Pliskin? You can unmute and ask away. Betty, do you have some more?
I don't think so, but thank you so much. That was great.
You're welcome.
Yeah, we're definitely interested in continuing the talk and the collaboration. Would definitely love to bring you to talk more with us, our survivorship team, at some point, and to try to get this incorporated, because we do find this. I've found in particular a couple of head and neck cancer patients, because they're getting radiation things to fields that are more proximal to the brain. And I've had a couple, I've sent you several patients over my years practicing. And so, but for these patients as well, head and neck, and I think this is important for all cancer patients, but for them, an automatic referral is speech therapy.
Okay, I gotta jump in though, because if you don't mind for a second, because Elizabeth is raising something in the chat.
Sorry.
Don't apologize. That's extremely important.
Yeah.
And what she says is accurate. There is a long waiting list for our services, but we prioritize our services. So at the back end of the waiting list, I'm sorry to say, are people who are waiting for attention deficit and hyperactivity disorder evaluations. At the front end of our list will always be our surgical, our medical, our neurological patients. So I just want to say, Elizabeth, that if you've encountered roadblocks, then please just reach out to me directly, and we can address that. So yes, it's true. There's a long waiting list, and there's a mental health crisis in this country, and we're struggling, as much as we can, like everybody else. But we will always prioritize, our medically ill patients and psychiatrically ill patients. So I'm sorry. So please continue, Dr. Mance. I apologize.
No, that's okay. I will probably come back and remember. This is me and my cognitive difficulties, which a little hormonally based. So I don't actually remember what I was talking about.
And my cognitive difficulties is, oh no, I'm going to forget what Elizabeth brought up. So I got to jump right in and say something right away. So I derail you. See how that works?
Totally. Now we see the need for neuropsychological. So, yes, Liz, I will take you up on the offer. Yes, Dr. Pliskin is super, super nice and willing to talk about patients anytime. I know we've talked about a couple of patients over the past couple of years, and he's always available. Great, great resource, and ready to talk to anyone about what is going on with a patient. So I know some folks are heading out. I had a couple other little questions. I think you kind of answered them though. We talked about diet, and you said you kind of took those patients, the brain cancer patients out. Oh, I do actually remember what I was saying. The referrals, that the speech therapy is an automatic referral. It's knee-jerk for head and neck. So we should try to talk to the oncologic services to create a knee-jerk referral to neuropsych for all cancer patients, because any cancer patient is going to experience some degree of impairment, right? Like everyone is getting some type of treatment pretty much. So that seems like something we should just build into the protocols, right?
Not going to get any argument from me.
I agree too. And, upon learning about neuropsychological testing, I'm like, oh, wow, like, why is everyone not using this? And getting help from your services, because provide very practical recommendations on, what's going on, why that might be a problem, and things that we can do to help. So yeah, all very, very important and again, we'll try to have you with the survivorship team so we can start working on that and helping it out.
Just try me out.
Anyone else have any other final comments for Dr. Pliskin? Thank you again for a great talk, and I will send out the recording to all if you want to re-listen to it, and if you want to spread it to other folks too. So everyone have a great rest of your Thursday.
You as well.
Okay.
And thank you.